And again, it's time to switch gears back to Dr. Agrelli, who's developing and something new and his ideas about the development of percutaneous endobental procedure. And I believe this would be probably one of the last frontiers to actually tackle zone zero aneurysms and aortic regurgitation in high risk patients. And once we have an answer and a good device for this, I think many of our high risk patients would actually undergo endovascular treatment in future. So over to you, Dr. Agrelli.
Thank you. Thank you. And first, let me congratulate my colleagues that present the trick valve. I feel happy and honored. Amazing result with something that it's a long time work that we are doing here. Thank you. I will talk about this new concept to the ventral debonus surgery, a way to do this by a percutaneous way, and present where we are now in this technology. As I presented before, we are working to keep this complex intervention safe and simple. Then it's something that it's our guiding way when we are thinking about new devices. Then we are looking how to do it safer to the patient. And I presented before, we have a complete portfolio for the valve treatment, and this is a way to move further and bring this new concept device to the routine. The ventral debono technique, it's proposed first in the 60s by these two doctors, Hugh Bentel and Anthony de Bono. It's a complete replacement of the ascending aorta, including the valve and with implantation of the coronary arteries. This surgery was modified during this time with some different approach to the surgery. We have including the mini incision for ventral surgery. We have surgeries preserving the aortic valve, implanting grafts for the coronary, or trying to use the bottom of the coronary artery. But the concept, it's always the same, the replacement of the ascending aorta and most of the time with the aortic valve. And this surgery is possible do the work of some pioneers that worked hard before this to bring the complex heart surgery alive, to have this replacement using extracorporeal circulation, using grafts, using valve replacement, and the idea of the circulatory intervention by catheters. Then we have a strong work to support this, and this is how these ideas were made in the 60s, and this is how we are moving forward. This is some initial idea of the intervention in the aortic valve. We can see a lot of devices, a lot of different concepts of valves, some ideas of techniques for the valve intervention. The first device for a aortic valve stenosis treatment. Then it's a long and huge effort to treat this patient, and we are improving in this direction. As I presented before, then after some years, after the extracorporeal circulation and the valve replacement, we saw the emerging of these new interventional techniques, percutaneous techniques to treat the aortic valve. Then we had this start in the middle of the 90s, and now it's something that we see every day, and it's a routine to have a TAVI implantation, a valve, aortic valve replacement by percutaneous approach. In the same way, for the aortic disease, we have this everyday routine, the aortic aneurysm treatment by the stent grafts. We saw close to 20 years ago, the starting of the branched grafts for thoracoabdominal patients. Then in the last few years, we saw this to the aortic arch replacement, and we see some trying to treat the ascending aorta using dedicated device. And then we start to see in a very few years ago, this idea of the endobental surgery. When we combine the grafts technology with the transcatheter valve technology, then we saw this concept start to be alive with this kind of ideas, associating the different device. It's just association. We are coupling this device to treat the ascending aorta disease. Then it's something that it's natural to see with the development of the technology. We try to expand this. Then we have that unmet clinical need to have a percutaneous approach to the high risk or inoperable ascending aorta patient or patient with the aortic disease plus the valve disease. Then we need to start to think how to solve this. Here's another, as this concept start to bring to us to have this development, some concepts start to be tested, like this kidney grafts to the ascending aorta replacement, the implantation of valve inside grafts implanted in the aortic position. Then we start to see this concept, these ideas being tested, being evaluated, and at the same time, with the increase of the TAVI use, we start to see some bailout techniques, implanting stents, coronary stents, together with the valves to avoid obstruction in the coronary arteries. Then here, I think that it's clear that we start to see this movement. It's not one single group working. We have this spread with across the world, with people doing this kind of intervention, the aortic intervention, the valve intervention. Then it's natural that we need to have this next step, and we start to put all these ideas together. Here are some examples of the kidney stenting technique for obstruction of the coronary artery after TAV implantation. And then in the 2018, we saw the first time this complete ascending aorta and valve intervention with the coronary artery connection. This case was done by Dr. Diego Gaia from São Paulo here in Brazil. It's something that we discussed a lot this case since 2015, and he concluded this implantation in 2018 to treat one patient. Was not an easy procedure, was a transapical approach with more than 6 hours of procedure, but with success after the implantation. Then we saw that the first step was made. We have something now to improve. And how we think to improve this concept of the endobental. This is our approach to this. It's basically what I present until now, the combination of different technology. We are using the self-expandable transcatheter biological aortic valve. We are using our platform for multi-branched aortic stent graft, and we are putting all this together, and we are complementing with coronary grafts, stent grafts. It's small size, self-expandable and balloon expandable stents, PTFE covered, to connect this piece, the main body of the device, to the coronary arteries. This is a more clear view of the device. We have this modular construction. Then we have the valve part. We have the aortic graft connected. And we have this internal branch to use and connect the coronary arteries with the bridge stent. We call the bridge stent the PTFE covered self or balloon expandable. This device, our approach to this, it's work with this off-the-shelf device and patient-specific design according the patient, according what we found and the real necessity of the treatment. This is the idea of the implantation. It's to have a pre-cannulated internal branch in the graft. Then we can start doing a partial deployment of the system. Then we can move these coronary guide wires in the coronary arteries. We can pre-cannulate the coronary arteries, and then we can fully deploy. As we have this patient-specific design, and we can have different assemblies of the device, we can have this delivery device from 22 until 28 French, the profile of the device, and we can use the arch approach, subclavian or axillary artery approach, or a femoral approach crossing the arch. And at this moment, we are looking only for the subclavian approach to make the device shorter and more easily control the rotation to position it the parts. The idea of this device is to use the dry tissue technology that we use for our trick valve device. Then we can have this pre-loaded, ready to use. Then it's not necessary to load this device in the moment of use. We can save time. We can be more. We can we can make safe the procedure, because we will assemble the company and we will check and we will test this before put this in the cath lab. For these surgeries, we need a very intensive planning. We start with the TAVI measurement of the aortic valve. We do the standard TAVI measurement. We check the height of the coronary arteries, the angulation of the coronary arteries, the size of the annulus, the size of the sinus, that it's important to be sure that we will have space to move with the branch. And then we start to do the measurement of the ascending aorta and the arch, like we plan a branched graft intervention. For the off-the-shelf design, we are using information, literacy information about the distribution and the sizing of the coronary arteries. Then we can recover this information from literacy to provide some off-the-shelf devices. We know that this will not fit for all the patient, and we will have this option to do the patient-specific design. And more than plan the device construction, we need to move to the planning of the intervention. And here we of like the measurement, we need to use a lot of techniques of the TAVI deployment, and it's mandatory to work with the commissural alignment to put the coronary grafts in the right place. And using this technique of the commissural alignment, we can move with the off-the-shelf design. Then we will have a design that aligned with the cusps. We will put the branch in the correct alignment with the coronary arteries. Then we use this for technique. We use this for planning. We will move in this direction to provide this device and implant this device. Then it's a summary of what we have in this device. We have a self-expandable graft with the internal branch, with the possibility of the patient-specific design. Then we can adjust the length of the design, the diameter, and the branch position for this. As a critical issue that we can have in this device, it's a paravalvular leakage. Then we insert a outer skirt, a long outer skirt valve portion to avoid and to prevent the paravalvular leakage. And we have in this device radiopaque markers that will help us to align during the deployment of this device. The delivery device, it's a device with a very controlled deployment. We have these two additional access to the pre-cannulation of the graft, and with a very slow and controlled deployment of the device. We can have this from 22 to 28 according the specification of the pre-cannulation and the device construction. Here, a small video showing an intervention in the lab that where we show this ability to open the branch, partially deployed, then we can open the branch, then we can move to select the coronary arteries, then we can fastly deploy the valve and the graft to avoid obstruction in the LVOT, and then we will have this channel to put the coronary grafts. It's a very fast deployment, then the coronary intervention. Then here again, the details of the device, using the bovine pericardium dry tissue, a nitinol frame with the polymeric outer skirt, with the internal coronary branch, and with preloaded and pre-cannulated device that allow us to offer this partial and controlled deployment. And related with the device, with the design, we offer the off-the-shelf and patient-specific. This is a new promising approach to the ascending aortic replacement, where we combine this technologies of TAVI and TIVAR. All these procedure, they are intensively studied. We need to have a very complex planning and preparation for the implantation. And using our dry tissue technology, we can bring this ready to use in the cath lab. Thank you.
Thank you very much, Dr. Agrelli. These are very exciting talks and presentations. All the four speakers and your innovative techniques, lecture, and the oration. So we are all flabbergasted by your way of thinking, the things you have in pipeline, and what goes behind making a valve and the newer technologies and the new era to come. We would definitely like to partner with you in forthcoming technologies and some future developments on endovascular side, both on arterial and venous side. And for the lack of a paucity of time, because we are running late, quite late, we would again, we'll have questions to you on the mail and the chat box. Just one question which has come to me from many people is, what are your thoughts about combining a TAVI with a multi-layer flow modulator? I mean, that takes care of a lot of things, the coronaries and the arch vessels. And if you just combine TAVI with that, we probably would be a simpler solution than these covered grafts.
Yes. I think that the multi-layer graft stenting, it's a technology that can be combined with TAVI. I think that definitively is something that we can have. And in this case, it's something that we can think about the independent devices, not all in the same device, but we will have a TAVI implantation and a separate device for the multi-layer approach. I think that it's something possible, and I'm not sure, but I think that for me it's something that probably we already have some attempt to this and some result on this kind of intervention.
Okay, thank you very much, and once again we thank you from the side of behalf of Asia Pacific Vascular Society and my co-chairman, Dr. Michel Henry.